So very good evening to you all, and thanks for joining in. And thanks, Dr. Pawan, for making it to this at a short notice. So the idea behind is that we are going to have a certificate course on advances in head and neck and tumor path, which will be mentored completely by Dr. Pawan Kirtani, who is a known faculty and has approximately 16 to 17 years in this field of histopath and has been working whole soul, and he has also has many other acclimates to his profile, that he's also a editor for many journals also. So I welcome Dr. Pawan, and now Dr. Pawan, you can take this mic, please. You can carry on, please.
Thank you, Dr. Raman, for those very kind words. Just to briefly introduce the session to you, so this is basically what we are aiming to do. This is a very brief introductory session wherein we're just going to discuss in very brief the advances that we have seen in the recent classifications of head and neck tumors, that is 2022. That is the fifth edition of the classification. So, the major changes that we've come across in this basically has been uh, in classifications of the salivary gland tumors, in some amount of classifications in the sinonasal tumors, and a very brief, or actually not very brief, the WHO has put out very clear-cut guidelines for applications and usage of HPV markers for diagnostications and prognostication as well as treatment in the case of head and neck tumors. Now, just to begin with, if I just take you to the next slide. All right. I hope everybody can see that. So to begin with, in this, the key changes that we've seen in WHO classification of salivary gland tumors 2022. The first one, there has been a lot of stress and a lot of importance that's been given to the molecular integration in the salivary gland tumors. And when we say molecular integration, increased focus on gene fusions to define distinct entities. So if we just look at it, it seems to be that WHO is now following up on the lines of CNS tumors, wherein in the current classifications, molecular techniques is almost has been made a basis for diagnosis, classifications, and treatment in CNS tumors. Likewise, we've also added a lot of molecular integrities, a lot of gene fusions, rearrangements for classifications of salivary gland tumors as well. For example, AKT1 for mucinous adenocarcinoma, gradually it's been seeing that wherever the entity or the modality is available, people are using it more and more just to give a very strong emphasis on the diagnosis and maybe on the prognostications as well. Next in lineup is introduction a couple of new entities, especially introduction of new benign ones, for example, keratocystoma, striated duct adenoma, and the malignant include the microsecretory, the sclerosing microcystic, and mucinous adenocarcinomas. In addition to this, what was or used to be called as a polymorphous low-grade adenocarcinoma has now been renamed and now is just called as a polymorphous adenocarcinomas. More or less, the terminology low-grade has been almost taken off the board. Number three, that there have been a couple of terminology updates, especially wherein the word variant has been replaced by subtype to avoid confusion with any genetic variants. For example, hurdle cell has been changed to oncocytic cell. So variants replaced by the word subtypes to avoid any confusion with genetic variants. In addition, the categories have been markedly expanded, inclusion of non-neoplastic epithelial lesions for better differential diagnosis. Or in other words, we are already aware that salivary gland tumors is one where there is a very wide scope of differential diagnosis. In very simple terms, if we explore the thing, we all are aware that pleomorphic adenoma is one of the most commonly seen lesions in salivary gland tumors. and practically almost a lot of malignancies such as adenoid cystic, such as myoepithelial carcinoma, such as epithelial myoepithelial, basal cell carcinomas, basal cell adenocarcinomas, all of these somewhere fall in the list of differentials for pleomorphic adenomas. And in the line of this, we have also added non-neoplastic epithelial lesions that we shall be discussing in detail when we start with the module in general in details. Following up, we have refined carcinoma classifications. Uh, Within that, recognition of specific molecular subtypes within some common carcinoma, such as mucoepidermoid carcinoma. That means within the broad heading of mucoepidermoid carcinoma, we've added molecular subtyping where they propose to use targeted treatments for better responses. And finally, we have new or revised diagnosis such as a microcirculatory adenocarcinoma that is defined as a low grade CA, defined by specific features and MEC MF2C fusion. Then we have a newly defined malignant entity that is sclerosing microcystic adenocarcinomas. Now, in the new one, mucinous adenocarcinoma has been recognized as a separate and a distinct entity, and Hurdle cell tumors have been replaced by oncocytic adenoma or carcinomas. So, this is in brief the changes that have been made to the WHO classification salivary gland tumors 2022. So, a lot of molecular integrity, newer entities coming in, terminologies have been redefined, the categories have been expanded to include reactive conditions, carcinoma classifications have been redefined, including molecular entities, and new or revised diagnosis or a renaming has been seen. Now, in the same line, as I said earlier, also we used to talk about HPV testing in malignancies, but we used to talk more in terms of cervical cancers, wherein we are using HPV testing as a routine for pap smears for screening. And we already know that cervical cancers and adenocarcinomas, now we them classify as HPV associated, non-associated. Now, something similar has been guided for use in the current head and neck cancers. The basic guideline objectives: one, in patients with oropharyngeal SCCs, non-oropharyngeal metastatic SCCs of unknown primary in the neck, and non-squamous head and neck carcinomas. There's a big question that are the clinical outcomes improved in HPV associated carcinoma compared to HPV independent carcinoma? That means if we are able to establish a causation of HPV in the documented CA, wherein we might be having targeted therapies or targeted drugs, are those associated carcinomas having a better clinical outcome? Yes or no? Number two, in cases of newly diagnosed oropharyngeal SCC, including multi site overlapping tumors, non oropharyngeal, non squamous, and cervical nodal metastasis of known or unknown primaries, the relevant outcomes, do they really depend on type of HPV testing performed? That means, do we actually need to go in for molecular, or we can simply rely on H or IHC typing? That means we can just rely on P16 and go ahead with the treatments, or do we really need to stratify that into low risk or high risk just the way we do with cervical cancers? Number three, does performance of specific tests or testing algorithms for HPV differ on the specimen characteristics such as size, age, fixation timings, time to fixation, the length of tissue fixation, positive P16 or HPV ISH test results? That means, in a broad term, do we really need to perform algorithms wherein we might be using P16 IHC in isolation? Or do we need to follow up that with the HPV hybridizations as well? Does combination of both or single either of them can be enough for that? We need to see on that. We need to work on that. Number four, in patients with oropharyngeal SCCs, can HPV status be new to determine whether it's a recurrent versus a new primary? That means whether HPV status, see, if a patient or if a cancer has been recurrent, in rough terms, can we assume that patient has been associated with HPV If it is HPV, then are the chances of recurrence more versus a new primary? So all are these guidelines, or should I say questions, that we are trying to answer with these guidelines. And all of them have been further subdivided. We have targeted guidelines, we have proper objectives that have been defined, and we will be discussing in detail again when we start with the module in proper sessions. Now, depending on these guidelines, there are a couple of key recommendations for HPV testing that has been recommended. Number one, pathologists should perform HPV testing on all newly diagnosed oropharyngeal SCC patients, regardless of tumor site or histologic subtype. That means it does not depend whether it's oral cavity, whether it's sinonasal, whether it's laryngeal or anything else. It does not depend whether it's conventional squamous, whether it is spindle cell type, or it is basolet, or it's basoli, or it's basaloid, or something else. HPV testing is becoming gradually mandatory or for all these newly diagnosed SCC patients. So sooner or later, we are going to come across this in WHO guidelines itself. Recommendations are there, but eventually it will become a mandate. P16 immunohistochemistry that we are already using in a lot of gynec cancers. Now, as per the new recommendations, they should be used as a surrogate marker for HPV testing, for high risk HPV testing in oropharyngeal specimens. Number three, routine high risk HPV testing is recommended for sinonasal SCCs and metastatic SCCs of unknown primary in cervical lymph nodes. Now, in some way, I'm not sure on this, that maybe it is just a possibility. I'm just kind of just hypothesizing that in many cases we are aware when we come across an SCC in cervical lymph nodes, majority of times we are able to pick up primary somewhere in the upper aerodigestive tract. It could be sinonasal, it could be the oral cavity, it could be laryngeal, it could be upper esophagus. But I'm just wondering, maybe sometime in future we might also see recommendations coming in for SCCs that might actually be evolving in lungs as well. So as of now, we are seeing HPV testing for upper aerodigestive. It's high possibility on the card that we might see the same somewhere down the line in lungs as well. Number four, testing should not be routinely performed for primary oral cavity, laryngeal, or non-squamous head and neck for prognostic purposes. Now, this is not exactly prognostication. This is more for diagnostication, for determining whether it's recurrence, or but it for more for treatment guidance, where we might be actually targeting treatment to cut down, maybe to excuse me, can you please put off your mic? Thank you. So, not exactly targeting prognostication, but yes, for diagnostication and treatment purposes, the recommendations are definitely coming in. So, this is in very brief the concepts coming in for HPV testing. And lastly, in the line, the simple talk or brief to revisions of sinonasal tumors in WHO classifications in 2022. As again, what we saw with salivary gland, the same model has been replicated. We are seeing a lot of molecular focus that is relying on genetic and molecular features, mutations, fusions. Obviously, histology remains to be the gold standard, but definitely with the genetic and molecular features improving accuracy and prognosis. So somehow what I'm kind of inferring now to these things, that the things first started with soft tissue tumors where moleculars almost became a mandate. Then it was followed by CNS tumors where it is again almost like a necessity. And now we're seeing the same pattern in oropharyngeal cancers, sinonasal tumors as well. So, though histology is and will remain the gold standard for diagnosis still, but for having a targeted treatment to improve accuracy and prognosis, we are now increasingly going to rely on genetic and molecular features. Mutations and fusions, just the way in soft tissue tumors, almost we are advising for sarcoma panels. It's quite possible that in the near future, we might again start advising for molecular panels in sinonasal tumors as well. Newer entities such as SNF deficient sinonasal carcinomas and HPV related multi-phenotypic sinonasal carcinomas, new defined entities. Now, earlier, almost grade 3 neuroendocrine tumors were almost considered to be a carcinoma, but now in the classifications, neuroendocrine tumors now graded G1 to G3 and classified differently from carcinomas. So, in broad sense, maybe we are just talking about a small cell carcinoma that will be taken as a neuroendocrine carcinoma, and the remaining carcinoids shall be graded as grade 1 to grade 3 depending on the proliferative index. Among the new additions, we have a surgical ciliated cyst as a benign cyst, emerging entities that define IDH mutant malignancies and AFF2 carcinoma may be what we are going to see. And as it already says, IDH thing evolved somewhere with CNS tumors, also seen with chondrosarcomas, though not much of a role. But yes, we are again seeing the same thing to happen in sinosel tumors. And along with that, we are going to see a more harmonized nomenclature that is aligning with the other WHO systems, separating such as ectopic pituitary neuroendocrine tumors. So, just to kind of summarize what we've seen in this, somehow what first started with soft tissue tumors, then followed up with CNS tumors. Now we are gradually seeing the same with oropharyngeal tumors, head and neck cancers, and also with sinonasal tumors. So, a lot of importance on molecular is being given. A lot of classifications are being depend on the neogene mutations. That means we are expect to see a lot of targeted treatments out there. The categories are being refined. The grading is being improved. Newer entities are and the nomenclature is being more kind of crisp and classically defining entities separately that are kind of behaving that might not be exactly benign neoplasm or a malignant neoplasm. We also have these reactive conditions coming into the classifications. And yes, HPV has always been there, but now maybe we are uh, gradually realizing it's important more and more, and the importance will increase in times to come. And maybe we see the same in lung tumors as well, wherein the treatments may be more targeted. We might start screening patients for HPV, and any HPV positive might be having under a close watch, already a close watch, and we might be having adding more and more treatments just in cancers to maybe decrease the intensity and reduce the disease longevity and to control the mutations, if any, and all that stuff. So, just to end, this is the flyer that we've already circulated with you. So, this is what we plan to do. So, as of now, what we are planning to do that we plan to start this course somewhere in the end of February, maybe the last week of February or in first week of March. So, we are targeting approximately 10 sessions, a high possibility that we might end up extending it. We plan to keep classes not almost every Monday of the week, and time shall remain to be 8 p.m. IST. And as we are seeing, it will be online classes on Zoom call.
Yeah.
Each class, I'll try to incorporate more and more number of clinical cases. I'll get you cases in real time. I'll try to get you those slides that we can discuss. What we see in images in books and internet, those are very, very ideal images. Whereas the scenarios, the kind of slides that we come across, the fixation and the preservation varies from place to place. The interpretations are very, very different in a practical sense. So we'll try to do accordingly that. And I'll try to also search that if we have come across any newer cases that we are already in the classifications. And I'll search on data as well where HPV is already being used in the newer classification. So that would be all from my side. I'll hand over the session back to Dr. Raman. Raman sir, please take over.
Yeah. Thank you, Dr. Pawan, for an excellent overview of the changes which have taken place in the head and neck path. And we are really eagerly waiting to learn from you these changes which have taken place. And people who are interested can log on to pathologymentor.com and also book these classes over there. And otherwise, you can send a mail on pathologymentor@gmail.com and or WhatsApp on the number given below, which is 95603 00846. and my team will revert back to you, and we can go ahead with it. Yeah, thank you everyone for joining in, and have a great day. Thank you.
Thank you, everyone. Thank you, Dr. Raman, for having me there.
Thank
Have a great evening, everyone, and see you soon.
you.